All right. So first of all, thank you to John and Senda for all their great work putting this together today. And let's see if I can figure this out. Okay. All right. So this is the mortality statistics that we've seen already several times today. I just wanted to point out two things. One is that the most frequent reported cause of death in patients with ALS is respiratory. And at the time of death, only a third of patients are using non-invasive ventilation. Now, this data is about 10 years old, but we don't have any reason to believe that that number has gotten any better over time. And so the next thing that we want to talk about is how we can better put together a program to reduce those respiratory deaths, most of which are infectious due to pneumonia. Now, the place that this has been studied the best is actually in intensive care units. And in intensive care units, we have what are called ventilator-associated pneumonia bundles, or a VAP bundle. Now, VAP bundles relate to our patients because most of our patients at home will be using non-invasive ventilation. And so many of these things will relate on an equal footing from the ICU to the home. First of all is elevation of the head of the bed. And we want to make sure that we do that and make that recommendation in our patients with ALS. Oftentimes that will require that a doctor prescribe a hospital bed. Frequently we wait until the end stages of disease when hospice is involved, but you don't have to wait that long. And if patients don't want to use a hospital bed, there are many options for wedge pillows that can elevate the head of the bed. And the other thing is daily oral care with chlorhexidine, which we're going to talk about in the slides coming up. There are concerns that are for our patients that aren't discussed in the typical VAP bundle. First of all is airway clearance, and there are no prescribed regimens for removal of secretions, and we know that that's an important thing. In addition, it hasn't talked at all about how airway clearance can reduce work of breathing, reduce secretion burden, and how we can help to improve that weak cough in our patients. So by starting this, we're going to talk about the issue of oral care and aspiration. We know that saliva is a big issue in our patients due to their inability to swallow and the inability to use their tongue. Aspiration is more likely in our patients, and if we can reduce the bacteria that's exposed in that, we're going to reduce the pneumonia rate that we see in our patients. Now, one thing I'd like to do is point out this picture of the tongue here. And what I would encourage you all to do is actually to examine the tongue on your patients. What you're going to be seeing is both fasciculations and atrophy. And then, do I have any respiratory therapists here? Oh, good. Okay. And pulmonologists. What I think is a very helpful thing is that if you have a patient who's weak, who's having difficulty coughing, difficulty relieving secretions, and difficulty getting off of ventilation, taking a good look at the tongue can be the one thing that's going to tell you what's going on. Because if you see those fasciculations and you see that atrophy, you need to think about motor neuron disease. Now, the other thing that I'm going to do is to give you a description of why this can be so problematic. Because our patients frequently will say to us, well, I know that you're worried about this saliva, but I'm already too dry. But yet they're drooling at the same time, right? So this is what we explain to them. If this is my hand as the floor of the mouth, pretend that my hand here is the tongue. Now, saliva should be coming up from the back of the throat, from the saliva and the parotid glands. The job of the tongue is to move around within the mouth and spread that saliva up to the hard palate, back to the posterior pharynx and the soft palate. But when the tongue is atrophied and it doesn't move, the saliva will only move forward, causing drooling. It will move down, causing microaspiration, but it won't get to the roof of the mouth, which is where the dryness is. So frequently, we're going to need to think about treating both a wet and a dry mouth at the same time. And why is this so important? Well, one of the reasons is that our bulbar patients frequently don't swallow effectively, and they end up using a tube feedings with a G tube. And this is a study that looked at the oral flora in patients that are getting G tubes. And what they showed was that almost 75% of them have bacteria within the mouth that are known to cause pneumonia. So we're talking here Pseudomonas, Klebsiella, Staph E. coli, and others. And it's much more prominent in these patients that are being G-tube fed as opposed to patients that are eating orally because of the changes in the saliva quality and the changes that occur because we're not doing as good an oral care on those patients. And so if we look at this, what you're going to see is that the increased amount of bacteria in oral samples is not only associated with the bacteria that are known to cause pneumonia, but are also associated with patients who tend to have weaker coughs and smaller vital capacities. So that means that the patient has more of the pathologic bacteria and is physically less capable of coughing and getting it out. And so oral hygiene is a big issue for these patients. There are definitely some things that are recommended. One is regular dental cleanings. This can be difficult for our patients because most dentists don't have a way of getting a power chair in and out where they have the dental equipment. And so you'll have to look in your community to find a dentist who is capable of taking care of patients with disabilities. I will tell you in Illinois, the University of Illinois Dental School, as well as Illinois Masonic, do have some ability to take care of these patients, but you just want to know in your own community what's available. In addition, you want to look at using a power toothbrush rather than a regular toothbrush. First of all, it's easier for patients and caregivers, but the other thing is that it tends to get into the gingival linings where the bacteria and the plaque are really building up and are more effective at getting it out. Other things that you can do, one is to use Paradex, which is here, which is the chlorhexidine mouthwash. Chlorhexidine is the antibacterial that's been shown to reduce pneumonias in the ICU. Also, usually from the ICU, are these SAGE kits where the toothbrush is attached to a suction device so that you don't aspirate the toothpaste liquid that you're using. These are really difficult to get on an outpatient basis. You may want to talk to your pharmacist about whether they can order them in. You also may want to look online. We've been lucky with things like Amazon and eBay. And the other thing is that if you have a girlfriend that's an ICU nurse, see if she can manage to find you some. In addition, there are antibacterial toothpastes. I just have two examples here, the Gum Detoxify and the Parodontax. And those are widely and easily available, whereas the Paradex you need a prescription for. So a lot of our patients would prefer to use the over-the-counter products. The next thing is to talk about this issue of thick versus thin. So the saliva that our patients have will change in quality. Sometimes it's so thick because of dryness, because of dehydration, because of mouth breathing, that the patient can't liberate the saliva, and because the mucus in it, it will hang right here in the back of the throat. Those patients, because it's so thick, will need something to wet and loosen those secretions. Whereas other patients are so wet that it's like water and this drooling is the major problem. Those patients need something that's a drying agent. So if you look at this, the first thing you're going to do is say, is my patient too wet? And if they are not too wet, are they too dry? And educate your patient that you're going to give them many tools to deal with their saliva and that they need to be able to change from day to day. If they're too thick, you may need to use something like saline nebulizers. And if you'd like to use the saline nebulizers, important to know, I should have put this on the slide, Medicare is no longer paying for the saline nebulizers. However, I'm sorry, I feel like an infomercial, but on Amazon, it's like $15 for a box of 100 under the Modudose. And so that's what we've been having patients do. In addition, make sure that the rooms in their home have humidifiers with them. And then there are some methods that have been used by ALS nurses for years, like papaya juice, pineapple juice, red grape juice, and the English swear by lemon drops. On the flip side, if the patient is too watery, that's when we start using things that are drying agents, like scopolamine and atropine. And so the patient needs to understand how they can flip back and forth as they need to. Now, there are some newer therapies, and I don't want to spend too much time on them, but I want you to know that they're available. The first one here is Botox therapy. So Botox is best studied after injections into the parotid gland. These are usually done by an ENT physician, but in some practices, we see that neurologists are doing them, especially neurologists who have come from a movement disorders background and are used to giving Botox. Also, if you're in an environment where there's an active PM&R group that treats cerebral palsy, they're very comfortable giving Botox injections. And so in any community, you may have differing resources to get this done. Typically, we just do the parotids first, and if that isn't enough, we'll add the submandibular glands, going from 2 glands to 4 glands. In addition, there are more drying forms of the Botox. There is Botox B, which is myoblock, and just this past year, a new form of Botox just for the salivary glands. The next thing is ligation, and this is a surgical procedure. This is a surgical procedure that literally goes in and ties off the glands altogether. It is, however, a 2-hour procedure, and it requires general anesthetic. So the only patients that we have been doing surgical ligation for are those that are already trached and vented, but regardless of that, have had multiple pneumonias and difficulty with keeping the airways clean. But in that situation, surgery is much better tolerated, and you can think about ligation. The next thing is the No-Bite 5. And I'm a big fan of the No-Bite 5. This is a device that was invented by an ICU nurse to make it easier to do oral care and to do deep glottic suctioning without having to use a catheter that might injure the back of the throat. These are available for sale just online. You can get them. We order these suction catheters for the patients. There's a light on the end here, and families have found that it really helps them, that their caregivers have an easier time with both suctioning and oral care. The other things that I want to talk to you about are some newer things on the market. The first is ablation. Now, ablation is really only done by kids, and there are very few centers doing it, and to my knowledge, no place in the Chicago metro area. And there are these new drugs coming out that are basically anticholinergic, but longer acting. And I don't know, have any of you guys had trouble getting scopolamine patches? We have had intermittent shortages on scopolamine patches, and we've had insurance companies that have refused to pay for them, mostly because they think it's something that you take because you're going on a cruise. And I'm like, no, my patient has ALS, not a vacation. And so the goal is that if we can get some of these longer acting drugs that are really meant just for saliva, that we may have an easier time. The other new kid on the block that we've just started using but have had good luck with is radiation therapy. And we do very low dose, 7 gray, not enough to cause any damage to the oral mucosa. Patients do need multiple treatments, usually about 4 times to the radiation therapy. But what we like about it is that once it's done, it's done. Unlike Botox, where you have to go back and be retreated every 2 to 3 months, with the radiation therapy, once you're done, you've completed. And so for our patients that have mobility issues or live far away, this has been a nice option. It's important to remember that cough is not just about how big is my breath. And if you look here at this classic diagram about what's involved in a cough, you'll see that closure of the glottis, which helps to develop a negative tugging force to bring secretions up and out, is a big component of a healthy cough. And in our patients who have vital capacities that look to be reasonably well preserved, if they have bulbar dysfunction and they can't close their glottis, they're still going to have significant weak cough. And so because of that, we believe that measuring cough directly is important. And this is just a reminder that we need an effective cough if we're going to prevent collapse of lung segments, although John did a really good job of describing that when he gave his talk. If you're going to measure that peak cough flow so that you get an idea of what the real necessary force generation is for cough, we recommend doing it with a peak flow meter. And this is a standard peak flow meter that's in everybody's hospital, but it's there to take care of asthmatics. And in an asthmatic, the instruction is take a deep breath and blow to see how prolonged the exhale time is. In this situation, the instruction is take a deep breath and cough. We want to see how strong that cough gets. Now, what we know is that if you get to 160 or less, those patients oftentimes require tracheostomy because they can't liberate secretions. In addition, what we have as a goal for an effective cough is 270 or greater. In those that are between 160 and 270, we recommend aggressive additives to improve airway clearance, and we're going to talk about some of these devices. What's interesting is that most of us do a single upright forced vital capacity in order to take care of our patients. And here's the reason why an upright forced vital capacity is not sufficient to decide what your peak flow is. So this is actually data from patients who have Duchenne muscular dystrophy, but it's the same idea, which is this. If you look at someone who has a preserved vital capacity at over 2 liters, what you'll see is that if you're using 270 as your cutoff for where that effective peak cough flow is, you'll see that a large number of these patients at that effective vital capacity also have an effective peak cough flow, but you're also going to see that some of them are much lower than 270 and need to start their cough assist support sooner than you would think. There's that 270 line. The first technique that we offer to patients is an Ambu bag, a resuscitation bag, used for lung volume recruitment. And do we have those for the demonstration? No? Okay, sorry about that. So the goal for these are to help increase the volume that gets into the lung, for chest wall expansion to improve range of motion at the chest wall. It also helps to improve vocalization. It also helps to relieve dyspnea, and it also helps to improve cough strength and improve the swallowing. But we're going to go through the swallow in a minute. This is how it's done for anyone who hasn't put one together. In addition to your standard Ambu bag and some extension tubing, you have this OneWay valve. And it turns out that the OneWay valve is the most important part of the system because it allows the patient to stack breaths one on top of another until the chest is completely inflated. And we typically do it with a mouthpiece, but it can also be done with a full face mask. Many centers use nasal clips to prevent the air from coming out through the nose, but the vast majority of our patients do not need it. They are able to close with their posterior palate and keep the air in their lungs. Once they have it, we recommend that they do 3 to 5 inhale efforts and then cough or breathe out afterwards. And with each one of these cycles, they should do 3 to 5 coughs per cycle. Most of our patients do this twice a day. And although typically we think about twice a day being morning and evening, in this sense, because it improves swallow with eating, we recommend that the twice a day be before your two biggest meals, typically lunch and dinner. And this just is a demonstration that shows what breath stacking is for those who don't know. So if this is your tidal breathing, in, out, you take a big deep breath in, and then starting at residual volume, you breathe in and you breath stack 1 breath in, 2 breaths in, 3 breaths in. And when you're at your full capacity, that's the MIC, or the maximum inspiratory capacity. This vital capacity is the amount that you can get into your lungs just on your own without the assistance of the Ambu Bag. This difference between the maximum inspiratory capacity and the vital capacity better predicts mortality in ALS than almost any other single marker that we've looked at. And the reason for that is that in patients who can effectively increase their maximum inspiratory capacity, they can still cough, and as long as they can cough, they can prevent infection, okay? The other thing about this, and this is data from Duchenne muscular dystrophy, but we think that it's relevant to ALS as well, and I'll show you why in a minute. If we look at the time that lung volume recruitment is started, and this is time 0, and we look at the drop in forced vital capacity, you see that the forced vital capacity drop has a pretty steep slope. But once lung volume recruitment is being done with an Ambu Bag, it really reduces the slope of the line of loss in forced vital capacity and helps to stabilize the breathing. And because of this, we introduce lung volume recruitment with an Ambu Bag as one of the very first maneuvers that we do when we meet a patient with ALS. The patient likes to hear that there's something that they can do actively that's going to help improve their condition, and that it's something that's without a drug. Sometimes I'm the most homeopathic physician in this entire hospital. I treat people with exercise and air like God made. But the patients like the empowerment that it gives them, and it helps them to understand that we're in it with them. So there's a lot on the emotional level with breath stacking as well. How early should you start? If you look at data, this is from Marta Kaminska, who looked at this data in Canada. Now, the reason that I bring that up is because if you look at the vast majority of centers in the US, they're just not breath stacking anybody, right? So you really couldn't have this discussion. But in Canada, for many reasons, this is a very, very common first step. And when they looked at the Canadian centers, the average was to start at about 60% and at a peak cough flow much over that 270 at 373. And basically, they're doing what we're talking about, which is very early initiation of Ambu Bags. And when they did that, they found that the quality of life scores of the patients were not inversely impacted by it. In other words, the patients didn't find that it was a burden. They actually found that it was positive. And then if we look then at how it improves their swallow, this is again Canadian data, looking at Stuart Cleary, who's a speech pathologist, and he said, I'm going to look at supraglottic swallowing ability in patients with ALS who are using an Ambu Bag to do lung volume recruitment. And so what he did is he went and he measured their ability to generate a supraglottic swallow. And there were some under treatment 1 who got an Ambu Bag and others that were controls. And what you could see is that at treatment 2 and at treatment 3, when patients were given an Ambu Bag to do lung volume recruitment with, their supraglottic swallow was significantly improved. And this is the data that has led us to our decision to tell patients that the Ambu should be done before the largest meal of the day. In addition, the Ambu Bag facilitates swallowing in part because it changes the positioning of where the epiglottis is. So let me show you what I'm talking about here. In patients for whom the lung volumes are very, very low, the epiglottis gets relatively pulled down. And because of that, it becomes more of a straight shot for food to end up collecting in the arytenoids and in the supraglottic areas, meaning that you would have aspiration that's late aspiration. In patients who have a more fully expanded lung, the epiglottis rises as the entire apparatus rises, and it puts a much better angle on her, helping to reduce that issue with late aspiration as well. And here's the other reason why that swallowing is so much better. So what you're going to look at here is this is what happens during a swallow maneuver, okay? First, the patient takes an inhale. Then they have to breath hold, and then at the end of the swallow, they exhale. Now, it's important to know that if you have a small tidal volume, the time that you're going to have during this breath hold is going to go down significantly. If you've put a bite of food in your mouth and you have not completed these swallow efforts, but you've run out of air for that breath hold, your body is going to take a breath anyway. And if the food is still in your mouth, you're going to aspirate it. The important thing to note about that is that if I send you for a typical video swallow, you are not going to pick this up because it's not a muscle dysfunction in the pharyngeal areas. It's a weakness of the diaphragm issue. And so what we frequently say to our patients is not just, can you swallow this, can you swallow that? But have you had scary episodes? Have you sat down for dinner and been afraid of what happened? And frequently it's the caregivers who will say, I'm afraid, because they see the scary episodes. And so what we tell them is if you do your lung volume recruitment effectively, if we can improve this, you'll have fewer scarier episodes when you eat. And that makes the caregivers as happy as the patients, but it also is our motivation. We say to the patient, look, if you do this and you gain some weight, we can stave off putting that G-tube in for a while. So, you need a little bit of the carrot with the stick. There are definitely some good resources for people who do not have experience with lung volume recruitment. I'm going to give you two of them. The first, this is CanVent. CanVent is a fabulous resource run by Doug McKim through the Rehab Center in Ottawa. This is the email or the website for it, and they have great videos showing how to use an Ambu Bag, but also how to do a lot of other lung volume recruitment techniques. This is our own Stephanie Hesser, and if you look at YouTube and put in Ambu Bag with Stephanie Hesser, this is what will come up. And she shows you how to do this technique and what patients need to do in order to make it work. I will tell you though, this is a true story. So you'll notice that it's a little bit little. This is a picture of Lou Gehrig behind her. So we had a new patient recently who was coming to us with a differential that included ALS, but we hadn't made a final motor neuron decision. And I started them because their vital capacity was low, and it's never too early to start an Ambu Bag. So we taught him in clinic, but then said, go home, watch the video, see what you think. So he watched the video, and he saw this picture, and he emailed us back, and he goes, I saw Lou Gehrig in the picture. Are you guys trying to tell me something? So I was like, that's pretty perceptive. These guys are smart. But regardless, it is a good video. Now, the other thing that is important in terms of lung volume recruitment is that it also helps if you can do what's called a manually assisted cough. So what happens is we do the inhale part with the bag, but if you can't do the exhale part on your own, it can be difficult. So to get both the peak cough low and the vital cough up with it, we recommend adding this. And the manually assisted part of that cough looks like it is right here in this picture. What I tell families is take your palm, find the belly button. You want to put the hand below the belly button, support during inhalation, and then press in and up during exhalation. excuse me, and that will help significantly. And I do try to teach this to family members when they're in the office. The other thing that I will tell you is if I do one of these cough maneuvers and I hold the belly and I ask the patient to either talk or cough, if they do better with this manual maneuver, the other thing that you should think about is adding a abdominal binder, a support binder. Low tech, we're talking some elastic and some hooks. The important thing is to remember to keep it low. Like I said, you want it at the belly button or below. You don't want it to ride up because that can impede diaphragmatic expansion. But if that works, it will help them while they're upright in their chair to cough on their own much easier. Now, what if we looked at all of these methods? Breath stacking, non-invasive ventilation, using a cough assist, which we'll get into in a minute. It turns out that there are huge error bars. Sorry, everybody agrees that an unassisted cough doesn't work. You can't just coach people to cough better. But all of these devices can be effective, and there's no standard deviation difference between any of them. It turns out, though, that there are patient-to-patient performance differences that are huge. And so the goal here is to make sure and have multiple options for your patient because any single person is going to do better with something else. So this is the old original Emerson cough assist. We're not going to look at that today. We have some of the newer ones available. We have things like the Vital Cough and the T70. But this dates back to the original data. 1956 is when these devices were developed as part of the polio epidemic. And they basically blow air in and suck it out in order to get secretions going. And if you look at expiratory flow, the original thought was if we increase the amount of pressure, we're going to get more flow. So that if you compare baseline to 15, 30, or even 40 of pressure, that the more pressure you had, the better patients will do. That is a sort of an old school way of thinking, and we're going to talk a little bit as we go forward here on our newer school ways of looking at these things. Oh, the other thing I wanted to remind you about in terms of cough assists is this really scary number here. These were hospitals that were polled as to whether or not they had a cough assist. Private hospitals, 60% of them didn't have one. Most other, quote, hospitals, which is your average rehab, nursing home, that kind of thing, 80% of them, no cough assist. Now, you were best off if you were at a university hospital. 43% of them didn't have one, but at least you were having a large majority that did. The reason I'm telling you this is because if your patients get sick and they have a cough assist, the assumption should be they have to bring their own to the hospital. The hospital won't have them, and family members need to know they may need to operate it themselves because the respiratory therapists are likely not trained on how to use them. Now, here's the concern, and this is where we get to the new school way of thinking here. And Senda, if I'm getting over time, just let me know. These are MRIs that were done by Jesus Sancho, and he looked at bulbar ALS patients, and what he found was that if you looked, that this was their baseline, and then as you did the exsufflation cycle on the cough assist, there was such a collapse of the posterior pharynx that you actually couldn't get anything out because the bulbar patients just can't do upper airway dilation. And so it's led to some challenges. Now, there's a couple of ways that we've dealt with this. One is using something called PAP on pause, which I'm going to show you. And the other thing is the use of laryngoscopy that can help us to better figure out what we need to do. So here's the laryngoscopy approach. This was done in Norway by Tina Anderson. And what she did was to look at the insufflation and exsufflation during patients that have bulbar dysfunction and looked at the amount of adduction that they had. And what they found is that in the patients who had significant bulbar symptoms, which are the patients in red over here, that during the insufflation, they were fine, except that there was a much higher rate of adduction, especially during exhalation, and that closure of the upper airway was particularly problematic for those patients. And what they found, and this is the most important part, is that the higher the pressure went, the more problematic it was. And that's what she's documenting on these pressures here. And so their recommendation is that in these patients who fail, that a decrease in inspiratory flow is much more beneficial than an increase, right? So if you look at the original data said 10 wasn't enough, go to 15 to 30 to 40. In fact, the current devices go to 70, right? But what we're saying here, especially for our bulbar patients, is that less is more, and that turning down your amount of pressure was actually more helpful than turning it up. This is what the PAP on pause solution looks like. What happens is when you get to the pause between inhale and exhale, in this device, which is the Vital Cough, you'll notice that we give a little extra positive pressure during the pause to help keep the upper airway open. And that's one solution to this problem that is only on the Vital Cough. We'll go through on the cough assist that's the T70 what the alternative solution is. And by the way, there's no head-to-head trials on these to say which is the best. Okay. The solution on this one is a vibration solution, and we're going to get to that in a minute. But just remember that we're going to have a different solution for this. We just talked about the fact that our bulbar patients frequently have closure of their vocal cords, and that pressure can frequently be the trigger. It's also important to know that just a little bit of saliva or postnasal drip or reflux can be enough to cause significant laryngospasm in these patients and get complete closure of the vocal cords. There are a lot of treatments that we've used. If it's severe enough, we have gone to tracheostomy for some patients in whom this has actually been life-threatening. But in my entire almost 17 years of doing this, I've only had to do that like a handful of times. For the majority of our patients, we use benzodiazepines, liquid. So lorazepam or diazepam in a liquid solution. The most common is lorazepam in Tensol, which is a 2 milligram per ml solution. And we have the patients do 1 to 2 drops under the tongue for immediate absorption in the middle of the laryngospasm episode. And the relaxation of the muscle happens almost immediately. And it can really make patients and caregivers much more comfortable because it is extremely anxiety provoking. The biggest difference that you're going to tell between cough dysfunction and laryngospasm, because there's a lot of trouble telling these apart in clinic, is the following question. When you have your cough, is the problem that you can't get secretions out or you can't get a breath in? Now, if they say to you, I can't get a breath in and it scares me to death, this is what's happening. And so they don't need an antibiotic, they need lorazepam drops. Okay? Now, if they're using the lorazepam on a daily basis or even 3 times a week, we recommend going to baclofen for routine daily dosing. Now, you're going to say to me, well, why don't you just do baclofen on everybody? And the answer is, Dr. Driss is going to get mad at me. And the reason is because in patients who have an upper motor neuron component to their disease, some of the stiffness that they have helps them to be able to still rise up out of a chair, to do some of their activities of daily living. And there is a chance that if I give this morning dose of baclofen, that they'll feel a little bit weaker, which is why I don't give it unless we have frequent need for lorazepam. And if we do, they just need the baclofen because in the end, it's the ABCs, and it always starts with airway. Airway trumps standing, unfortunately. The next thing is to look at high-frequency chest wall oscillation. This is a therapy that we also like using in our patients with bulbar dysfunction because they don't have to use the upper airway at all. And for patients that have chronic microaspiration, what we find is the use of this device provides vibration to the chest wall that increases mucus flow rates. It focuses on the small and peripheral airways to make it easier to keep them clean, and it thins the secretions because of the vibrations and helps them to get liberated. And if you look at this data, what you're going to see is that the use of high-frequency chest wall oscillations in patients that have neurologic diseases increases their ability to be tracheostomy-free. And what we like about it specifically in our patients with ALS is that if they have cognitive impairment or executive function problems, which we see in our patients with frontotemporal dementia, you can still do this therapy really easily. Whereas something more challenging with learning, like an Ambu Bag or a cough assist, may not be a realistic possibility for someone with significant frontotemporal dementia. And then the last thing is, this is data from myself and Noah Litzen looking at a large administrative database of patients with neurological disorders, not just ALS. And what we showed is that there's a significant decrease in total cost and a decrease in inpatient days and a decrease in number of pneumonias for patients with neurological diseases who were prescribed a therapy vest. And so we think that this has really helped us with insurance companies to get coverage when we hadn't in the past. The next thing is to look at the use of vibrations together with pressure. Now, for those of you who do not know who this is a great guy. His name is Dr. Bird, and Dr. Bird actually invented some of the very first mechanical ventilators. He was an engineer in the Army during Korea. Any of you guys ever seen MASH? Yeah? So the history behind MASH was that once we had small portable mechanical ventilators from Dr. Bird, you could now go into the field and rescue these guys and get them safely out to larger hospitals. I mean, this guy's a big deal in the history of the US, and this is him getting the Presidential Medal of Freedom Award. Now, it turns out that Dr. Bird's wife had COPD. And she had tons of secretions in her chest, and they were living in California in the desert, and it was dry, and she couldn't get her secretions out. And he said, well, I think I'm going to make a device that delivers a nebulized therapy to the airway along with vibrations that will provide shear forces to liquefy those secretions and get them up and out. Now, he did this in the 70s, and there was always a difficulty getting the device actually widely available and paid for. There is, however, a new device on the market called the MetaNeb, which does sort of a similar job. And we have MetaNebs here today, right? Oh, man, breaking my heart. Okay. Okay. All right, well, see, that's what happens, right? They're all in use. That's a sign. So this is one of the old devices from the 70s. We've clearly gotten a lot better since then. And what you see is that instead of having a ventilation that's kind of slow like this, that instead we put percussions through the airway. And what do those percussions do? They open up these mucus plugs, they allow the alveolus to drain and get air in and out better, but more importantly, it increases the total amount of secretions that come out after the treatment. Now, this is an example of a home version that we've just put in a paper that we're waiting here to, knock on wood, get published. And this is the research version. I guarantee you that when it comes out in the real version, it will not be like this. It's hard to tell in this picture. This is a compressor that's the size of an end table. We actually had to have professional movers come and bring these to the patient's houses. But when we have the real version for home, it'll be about this big. And in the hospitals, we already have them because, hospitals, you have pressure in the wall, right? You just plug it in. And this is what it looks like in the hospital. It's super small. And we do alternating pressure and vibration within a treatment that lasts about 20 minutes. I have a pretty graph of this on the next paper. And when we did it at home, what we found was that there was a significant improvement in patient quality of life. They found that it was easy to use and it was helpful for both lung volume recruitment and liberation of secretions. And this is that graphic that I was telling you about. For those of you that are respiratory therapists who may now be thinking, my God, is she going to have me do a vest treatment followed by a cough assist, which would take you about 45 minutes. What our therapists like is that you can do this in about 10 to 15 minutes, right? Because the treatment itself is 2.5 at each stage of either pressure or vibration. And there's the setup and the takedown of this, but it's only one device. We studied 5 ALS patients, and we had 5 others that had actually cystic fibrosis. And basically 95% in the motor neuron group said were compliant with the device and kept it afterwards to continue to use it. Truthfully, even if they didn't want to keep it afterwards, we probably would have, since we needed movers to get it back in and out of the house. I'm promising you the new one will be better. Now, what's the advantage here? The advantage here is that the flows are a lot lower and the timing is a lot less for patients at home. The only problem, of course, is that there's no exhale maneuver on this, so patients would need to do a manually assisted cough. And the only one of our patients who said they had any problem with this, it was due to the fact that there was no expiratory maneuver. And so what they would do is they would do a treatment like this to relieve the burden of the secretions, but they'd still have to use the cough assist afterwards to get some of that stuff out. And so I think looking at single mode therapy is always going to be a challenge for our patients. One of the options that's available right now is to use vibrations that are on the T70. Remember I said that PAP on pause was one option for those bulbar patients that would collapse. The other option is to use oscillations during the treatment with your cough assist. And we have that today. I believe somebody's got, we have T70s? Oh, you're letting me down, man. So what I will tell you, this is a super interesting paper. So this was done by a conglomerate with Jesus Sancho and Michelle Chatwin. And they looked at using oscillations for no oscillations during inhale only, and then during exhale, and then during inhale and exhale. And these are the in and out pressures. So you can see this is exhale, this is inhale and exhale. And they didn't find that there was any difference between those who had oscillations and those who didn't in terms of total flows or in terms of peak cough pressures. And so they tried to say then that the vibrations were of no benefit. What's very interesting, though, is that I've seen both of these guys give national and international presentations since then, and their videos are all on YouTube, and I'm telling you right now, they are using continual oscillation in all of their patients. So I think that maybe the problem with this paper is that they weren't looking at the right outcome. They should have looked at how the patients felt. They should have looked at the amount of secretions that came out. They should have looked at the differences between their bulbar and their non-bulbar patients. None of that was done in this study. And the reason that I'm telling you that is because sometimes I think the oscillations on here get a bad rap, but I think given the amount that they're actually being utilized, that it's something that we should still consider doing. And then one last thing, this is the SIP ventilation that Dr. Coleman was talking about. So this is a typical SIP interface, which allows a patient to take a breath in as needed to assist with cough, dyspnea. It allows them to breath stack so that they can expand their lungs. And what you see is that in patients who are successful in this therapy, meaning that they can breath stack and that they can use that breath stacking to get their peak cough flow greater than 180, those patients do very, very well even after they initiate mouthpiece ventilation. Their ALS FRS scores stay much higher than people who don't. And the same is true for the bulbar patients, provided that they're successful. Okay? So we typically will say, oh, well, a bulbar patient isn't going to be able to do this because they can't do the mouthpiece. Or a bulbar patient isn't going to be able to do this because they have too much saliva. But what we find is that if the bulbar patient is successful, if they can do it, they will get the same benefit in terms of their ALS FRS. And of course, the question is, why does it work? And we have some interesting suggestions, but we think the biggest reason for it working is that it gives the patient independence in terms of their ability to cough and control their own ventilation. And this is my final slide. I hope I'm not too far over here. And I wanted to finish this because it is the ultimate demonstration of SIP and how SIP causes independence or supports independence. This is a guy named Ed Roberts. Anybody here from San Francisco? Nobody? Oh, it's a bummer. Ed's from San Francisco, and so there's a BART station named after him. So sometimes if we have people from San Francisco, they've heard of him. Ed was a guy who got polio as a child and was in an iron lung. And when he came out of the iron lung, the only option he had was a full mechanical ventilator, which in those days was the size of a washing machine. And there were no such thing as masks. So he used it with what we would see as really SIP ventilation. And the University of California told him he couldn't go to college because in the 60s, the actual letter they sent to him said, cripples can't go to school. And so he founded what was called the Rolling Quads, and they protested for the, quote, rights of the crippled. We've come a long way in this country. He is known as the founder of the Access Living movement, which says to us that our goal as physicians, my goal as a pulmonologist, is to facilitate high-quality, community-based living for all my patients, no matter what their disability is, which is why we all need to learn how to do SIP ventilation. So thank you to Senda and to John, to our wonderful team of neurologists, and to our wonderful team from the Les Turner Foundation. Thank you.